Yes, sir.
Yes, you are there. Na? Please switch on your video, sir. Thank you.
Sorry, I can't get you, sir.
Switch on the video, sir. Yes,
Yeah, I
sir.
thought that sir will be presenting. That's why I have not switched on my video.
No issues.
I'm the second presenter. That's why.
Yes, sir. Please start.
So, good evening, doctors. I am Girish Malhotra, sales head with India Bulls Pharmaceuticals, and I welcome all the doctors in our today's webinar. That is our e-Gurukul learning session. Before we go into the webinar, I would like to share a little brief about India Bulls Pharmaceuticals. India Bulls Pharmaceuticals clocked 112 crore last financial year with its robust presence in chronic, subchronic, and acute therapeutic segments. India Bulls is operating with 9 divisions at present, covering various specialties in cardiovascular, derma, gynae, and critical care segments. With the prescription base of over more than 7 lakhs per month and with more than 25,000 prescribers pan India, we feature among the top 100 pharmaceutical companies of IPM in value and prescriptions. As far as our chronic therapy is concerned, that is Orient division of India Bulls, with the academic programs like NEEF and Converge that has been conducted last year very successfully, our endeavor has been totally dedicated towards developing inroads into a specialty segment. Now, considering the COVID pandemic, which has impacted one and all of us in one or the other way, we in India Bulls have initiated an online learning platform that is eGurukul, where eminent specialists and academicians they share their experience, expertise, clinical insights on the management of various metabolic diseases like diabetes, hypertension, and cardiac complications in these tough times. I extend my very sincere thanks to our renowned speaker, Dr. Arun Pari, a cardiologist from Chennai, and Dr. Shriram, a renowned endocrinologist and diabetologist from Chennai, who are going to speak on the pearls of wisdom in hypertension and overview of hypoglycemia with a special focus on DPP-4s today. I'm equally confident that this session would be of a great clinical use to all our eminent participants who are taking their valuable time out of their busy practice schedule. So now I would like to hand the session to our medical advisor, Dr. Abhay Mane, for introducing the speakers and the topics and taking the webinar session ahead. Thank you very much. Over to Dr. Abhay Mane now.
Thank you, sir. Thank you so much. Good evening, everybody. I welcome everybody, our speakers, as well as my team members, and as well as the audience to this eGurukul webinar. And today we will all have two sessions. So our first session is on cardiology and hypertension, which we have named as a Pulse of Wisdom in Hypertension. In which our first speaker, Dr. Arun Pari, will give his wisdom, the pulse of wisdom. So Dr. Arun Pari is a consultant cardiologist at Bharat Hospital, Chennai. And along with many fellowships, he has also received fellowships in interventional cardiology. He has numerous publications to his credit, and he has been a participant of various national and international conferences. So I welcome Dr. Pari sir here. So thanks for joining us today. After our first session, we will have Dr. Sriram S. Speaking on our second topic, which is the overview of hypoglycemia and focus on DPP-4 inhibitor. So Dr. Sriram S. is a renowned consultant physician from Mani Lakshmi Clinic, Chennai. He has been participant in various national as well as international conferences. He has been speaker and presenter at these congresses. He has conducted multiple workshops, which also included diabetic foot workshop. He has published his original research work in various journals, national as well as international. So we are very happy and we are very privileged to have you here as our second speaker today. I also have a link to the questions. So I will be the moderator for today's session, and I'll also read out the questions My request to audience is not to hold back any queries. Please do not hesitate. This session is not for us. This session is for you. So please ask as many questions as you can. And you can also suggest us some different topics, some another topics related to diabetes and cardiology in the comment boxes. So without wasting any further time, I'll hand over our session to our first speaker, Dr. Arun Pari, Pulse of Wisdom in Hypertension.
Good evening, everybody. I'm Dr. Arun here. Today we will be having a brief overview about the most common topic in cardiology and general medicine, which is treatment of hypertension. Next. Next slide, please. Next slide, please. So we will briefly see about how why to treat high blood pressure and what are the various ways to measure the blood pressure and what are the guidelines and how to treat, which includes the various aspects of lifestyle modification, drugs, and devices. Next slide, please. So, what is the burden of hypertension in the globally? Actually, raised blood pressure is the leading cause of the death globally. It accounts for nearly 10 million deaths per year, and high prevalence of hypertension in India. There is a very high prevalence of hypertension, with almost one out of every third Indian adult who is affected with high blood pressure, and it has an adverse impact on the cardiovascular morbidity and mortality, and hence the risk of cardiovascular events are more in patients with untreated blood pressure, high blood pressure. Next. So if we see this chart, it clearly shows that there is an increasing trend of cardiovascular events, the relative risk of myocardial infarction, and also the relative risk of cardiovascular death and stroke are all more in patients with raised blood pressure. As, and it increases it increases with the increase in systolic blood pressure. So high systolic blood pressure leads to increased risk of cardiovascular events. Next. So in this graph, it's very obvious that about 45 to 50% of all cardiovascular deaths, that is nearly 9 lakh deaths per year, are due to hypertension. And in the United States, it is almost 4 times more. It causes nearly 4 lakh deaths per year uh, in the US. Next. So, as you all know, high blood pressure is called the silent killer. It causes damage without causing any symptoms. Most of the nearly 50% of the patients who have hypertension are asymptomatic, and the time when their blood pressure, uh, high blood pressure comes to notice is only when they present with some form of target organ damage, like CVA, cardiovascular accident, cerebrovascular accident, visual defects, acute myocardial infarctions, heart failure, chronic kidney disease, and sexual dysfunction. So most of the times, high blood pressure is silent without causing much or major symptoms. Next. So how to measure blood pressure is it's a very important to know that the patient should be comfortably supported with back support, and the room should be quiet with a comfortable temperature and neither too cold nor hot, and there should not be any intake of coffee, or patient should have not exercised or smoked for the past 30 minutes, and the patient should have an empty bladder, relax for 3 to 5 minutes, and three measurements should be taken, each measurement at an interval of 1 millimeter, and the average of the last two measurements are take, taken generally. So the patient should not talk during the measurement or in between the measurements, and it can use either an electronic BP apparatus or a sphygmomanometer. The feet should be rested flat on the floor, and the cuff should be very accurate to fit the arm size. So in the initial evaluation, we measure BP in both the arms simultaneously. If normally there is a 10 millimeter difference uh, between both the arms, if the difference is more than 20 millimeters of mercury between both the arms, then we need to further evaluate the patient for any form of coarctation or stenosis involving the major vessels. So the standing blood pressure we have to measure in treated hypertensives after 1 minute and again after 3 minutes whether there are symptoms suggesting orthostatic or postural hypertension, and in patients with diabetes and also in elderly patients. So for the manual devices, it is very important to make sure that the cuff bladder must cover 75% of the individual's arm circumference. For electronic device, the cuff which is given for the particular instrument should be used. Next. So this just to show you how blood pressure was measured in the initial times, where they used the Poiseuille's mercury manometer, and later on the sphygmomanometer was invented in 1981, and the Korokov sounds were identified to measure the distinguish systolic and diastolic blood pressure. And in the 1990s, the oscillometric method was described for home and office BP records. So today we generally use the sphygmomanometer to measure the blood pressure or the electronic instruments. Other instruments, novel blood pressure devices, new devices are the SomnoTouch non-invasive blood pressure monitoring and the Omron heart rate and the capacitance sensing blood pressure. Next. So if the BP is high in the clinic, one should distinguish between white coat hypertension and sustained hypertension. So different BP states are there. That is normal. At clinic, most of the times the BP is normal in 17% of the patients, and it is noted to patients with white coat noted to have white coat hypertension in 27% of the patients. Uh, so out of the office BP is more strongly associated with risk than routine in BP in clinic high blood pressure. Next. Previous slide, please. Where there is marked office BP elevation without home monitoring, and conditions in which the mass hypertension is more common, that is high normal office blood pressure and normal office blood pressure in individuals with uh, home monitoring devices or at high total cardiovascular risk, and postural and postprandial hypotension in untreated and treated patients, and in evaluation of resistant hypertension and exaggeration and evaluation of the BP control, especially in patients with uh, higher risk patients and exaggerated BP response to exercise, and evaluating in symptoms in patients consistent hypotension during treatment, and assessment of nocturnal BP values and dipping status like suspicion of nocturnal hypertension such as sleep apnea, diabetes, chronic kidney disease, and in patients with autonomic dysfunction. Next. So these are the various studies and various levels of JNC, Joint National Committee guidelines, which you see from JNC 1 to the present JNC 8 guidelines and also the guidelines. So if you see the various levels of BP which have been mentioned in these guidelines, on an average, a BP of a blood pressure goal of less than 130 systolic and less than 80 millimeters diastolic is a reasonable value which one should aim to achieve. Next. Next. So this is the JNC 7 guideline as well as the 2017 American Heart Association, American College of Cardiology guideline, and also the Indian Hypertension guideline, which is briefly summarized here. So, if the BP in the 2017 guidelines, a blood pressure of less than 120 systolic and less than 80 is considered normal, and if it is 120 to 129 and less than 80, it is considered a pre-hypertension stage in JNC 7, and elevated blood pressure in 2017 ACH guideline. Whereas in Indian hypertension, it is near normal. So high normal blood pressure is when the systolic blood pressure is 130 to 139 on 80 to 89 systolic. Stage 1 hypertension is when the BP is 140 to 159 and 90 to 99 as per Indian guidelines. And stage 2 is if it is systolic blood pressure more than 160 or a diastolic blood pressure more than 100. It is called stage 2 hypertension. Next. So, what is the criteria for hypertension? This is based on the ambulatory blood pressure monitoring as well as the home blood pressure measurements. An office BP of more than 130, more than 140 systolic, or and more than 90 millimeter diastolic is significant. In an ambulatory blood pressure monitor, on a 24-hour average blood pressure of more than 130 or more than 80 millimeters is considered significant. The daytime average should be more than 135 systolic and more than 85 diastolic, and the nighttime or sleep average should be more than 120 or more than 70 millimeters. The home blood pressure we consider to be significant when it is more than 135 millimeters systolic and more than 85 millimeters diastolic. Next. So various guidelines are there for monitoring and control of high blood pressure. See, all these
So your audio is muted. Yeah.
next.
Yeah.
So who to treat? So as you all know, less than 120, less than 120 and less than 80 systolic blood pressure. If a patient comes with any symptoms, they should be reassessed after 1 year. And if the systolic blood pressure is more than 120, we consider it to be elevated, and we advise them non-pharmacological methods like dietary restrictions of salt and daily exercise, and we review them after a period of 3 months minimum. If the blood pressure is more than 130 systolic and 81 millimeters diastolic, they fall in the stage 1 hypertension. And if the atherosclerotic cardiovascular disease is, if the risk is more than 10%, then we start them on non-pharmacological therapy and minimal pharmacological therapy. And if it is less than 10%, we put them on diet and exercise. And we monitor them after a period of 1 to 2 months. And in stage 2 hypertension, where the systolic blood pressure goes more than 140, we advise pharmacological therapy as well as non-pharmacological therapy. And we review them every month initially until the blood pressure is controlled. Next. So what are the lifestyle modifications which would help to reduce the high blood pressure? The first and most important thing is weight loss. And we should remember that every kilo of weight loss will reduce the systolic blood pressure by 1 millimeter mercury. And the DASH type diet, that is dietary approach to stop hypertension, a kind of a diet which includes intake of fresh fruits and vegetables, reduces the systolic and the mean blood pressure by 11 millimeter, and dietary sodium restriction to 1500 milligrams per day reduces the blood pressure by 5 to 6 millimeter on an average, and potassium rich diet also increase the dietary potassium also helps to reduce the blood pressure. Aerobic exercise of 90 to 150 minutes per week reduces the blood pressure by 5 to 8 millimeters of mercury. And reduction in the alcohol intake also helps to reduce the blood pressure. Next. This slide shows that in the accomplished trial, they found that the combination of ACE inhibitor plus calcium channel blocker is superior to ACE inhibitor and diuretic in reducing cardiovascular events in patients with hypertension who are at high risk. And also the chlorthalidone is preferred and antihypertensive diuretic based on the basis of its prolonged half-life and proven trial in the reduction of incidence of the cardiovascular deaths. Next. The RESOLVE trial has shown that 71% of the hypertensives achieve the target blood pressure goal of less than 140 and 90 on the combination of olmesartan, amlodipine, and hydrochlorothiazide. Next. So now the treatment, just a summary of the treatment. For primary prevention of the and treatment of hypertension, the first line therapy is usually a thiazide diuretic, chlorthalidone or hydrochlorothiazide, along with an ACE inhibitor or ARB or a combination with the blood pressure short control. Patients with diabetes and chronic kidney disease, the first line therapy would be ACE or ARB. And the add-on therapy for diabetics would be a thiazide diuretic. If it is still not controlled, we would go for a calcium channel blocker or a beta blocker. In patients with coronary artery disease, the first choice is a beta blocker along with an ACE-ARB, and thiazides and, of course, calcium channel blockers for additional BP control. Patients with old CVA, again ACE-ARB and thiazides are preferred. And patients with LV dysfunction, ACE-ARBs are used along with a loop diuretic or a thiazide diuretic in addition to a beta blocker. In severe heart failure, an aldosterone antagonist is preferred along with hydralazine and isosorbide dinitrate. Next. So in pregnancy, only the following medications are recommended. That is labetalol, nifedipine, and alpha-methyl dopa and hydralazine, ACE-ARBs, and mineralocorticoid receptor antagonists like spironolactone are contraindicated. Absolutely. Next. So this slide shows the office blood pressure target range in patients with hypertension, hypertension with diabetes, chronic kidney disease, and coronary artery disease, and those with prior history of stroke and TIA. It should be noted that the diastolic blood pressure target is 80 to 70 millimeters of mercury, and the target blood pressure is slightly high in patients with CKD, where the target is nearly 140 to 130 millimeters of mercury systolic. Next. So in patients with left ventricular dysfunction, our goal of BP should be less than 120/80, and those with diabetes less than 130/80, chronic renal disease less than 130/80, and with patients with CAD or CAD risk equivalence, again less than 130/80 millimeters mercury. Next. So secondary hypertension should be considered in early onset hypertension, resistant hypertension, sudden BP control deterioration, and hypertensive urgencies and emergencies. And we should also exclude pseudo-resistant hypertension and hypertension induced by substance abuse and drug-induced hypertension prior to investigations for secondary hypertension. Next. So what are the general factors which could elevate blood pressure? One is diet rich in sodium and high intake of alcohol and caffeine, obesity, herbal supplements, and drugs like cocaine and methamphetamines, medications like oral contraceptives, hormone replacement therapies, and serotonin and norepinephrine reuptake inhibitors, steroids, non-steroid anti-inflammatory drugs, cyclosporin, tacrolimus, and sympathomimetic agents. So, while taking the history on before treatment with hypertension, all these factors should be considered and ruled out. Next. So, what are the common causes of secondary hypertension? Renal diseases like parenchymal disease, that is chronic kidney disease, intratus stenosis, primary hyperaldosteronism, Cushing syndrome, congenital adrenal hyperplasia, primary hyperparathyroidism, pheochromocytoma, and thyrotoxicosis. These are all the endocrine disorders. And aortic coarctation and obstructive sleep apnea should also be taken into consideration in young hypertensives. Next. So, non-pharmacological measures and devices to control hypertension are the renal denervation therapy, carotid sinus activation, carotid body ablation, and median nerve stimulator. Um, these target the mechanical aspects of the circulation, but science and evidence has proven that these measures are not satisfactorily significant in reducing high blood pressure, and hence they are no longer used in clinical practice. Next. So, coming to the drug treatment strategy of uncomplicated hypertension. So, initial therapy we usually start with an ACE/ARB, ACE inhibitor or ARB. Then, if the blood pressure is not controlled, we consider adding a thiazide diuretic or a calcium channel blocker. Step 2 is the triple combination of ACE/ARB, calcium channel blocker, and diuretic. And still, if the hypertension is not controlled, it is called as resistant hypertension, where the blood pressure is not controlled by three drugs, one of which is a diuretic. Then we add spironolactone or alpha blocker or a beta blocker, and further investigation may also be considered. Next. So, a brief summary of the treatment. So, the drug treatment should be aimed to achieve the blood pressure of less than 140/90. If it is more than 60 years, optimal target should be 130/80 less than 65 years. And in patients with essential hypertension, reduce systolic blood pressure by more than 20 millimeters systolic and 10 millimeters diastolic. Next. So the optimal treatment is up titration to the target. So first we start with low doses of ACE/ARB and calcium channel blocker. Then we go on to the full dose of ACE/ARB calcium channel blocker, followed by the triple drug combination ACE/ARB calcium channel blocker and diuretic. But if it is resistant to these three drugs, then we consider adding the spironolactone. When diuretics are considered, we preferably use thiazide diuretics. Next. So, what is the approach to improve the adherence to therapy with regard to the patient? We should ask them the history and assess the adherence at every visit. They should be taking pills on a regular schedule with routine daily activity and use of long-acting once daily dosing agents, and use fixed dose combination pills, and utilize the unit of use packing. That is blister packing when patients can be uh, it can be helpful to patients to monitor whether they have taken the drug or not. Next. So when the hypertension is refractory or when there are secondary causes of hypertension like endocrine, we generally refer them to an endocrinologist. And if there are drug interactions and intolerance to medications, and if there is end organ damage, we then refer them to a patient with hypertension to the concerned specialist. Next. So as you all know, hypertension is a silent killer, and every patient should be properly screened by after and proper BP measurements. And first, they should advise strongly to follow lifestyle modifications, and medication should be started based on their profile to reduce the risk of cardiovascular events, and they should be monitored to achieve the 24 hours BP control and to achieve the target BP, and also the side effects and adherence to therapy should be regularly and frequently monitored. Next. Thank you very much for the patient.
Thank you, sir. Thank you so much for a wonderful presentation. Thanks a lot. Now, moving on to the second presentation, I request Dr. Sriram S. to take us through the second presentation. Thank you, sir. Over to you.
Good evening to everyone, and I would like to thank the organizers for giving me this opportunity to present this talk today. And I hope all of you are in good health and facing this COVID situation in a healthy way. And today my topic is about overview of hypoglycemia. Special focus will be on DPP-4 inhibitors. As we all know, hypoglycemia is a very common symptom and a condition which we come across in our day-to-day practice. Many of the patients who are diabetic and also those who are non-diabetic experience hypoglycemia, especially hardworking people like doctors who skip the meals or who have the breakfast or dinner at delayed times. That is also possible. And some of the patients who are on some specific drugs like insulin, or some of the patients who are on sulfonylureas also face hypoglycemic episodes. Some of the hypoglycemic episodes are very disturbing that some patients even stop taking insulin after experiencing one episode of hypoglycemia. So it is our duty as physicians to educate our patients regarding the possibilities of hypoglycemia during treatment, especially when we are trying to get the blood sugar levels under strict control. There are chances of going to hypoglycemia, and we have to educate the patients and their families also regarding how to manage the hypoglycemia and also to prevent the further episodes of hypoglycemia. The outline of today's speech is understanding hypoglycemia, management of hypoglycemia, and a short note about DPP-4 inhibitors. This is the physiology which is happening in our body. As we all know, pancreas is the organ which is responsible for glucose metabolism in our body. There are two types of cells, alpha and beta cells, which secrete glucagon and insulin. They both help to maintain the balance of blood glucose in our body. Other hormones like glucocorticoids and adrenaline also play an important role. There are two major processes which happen in our body, that is glycogenolysis and gluconeogenesis, which is breakdown of glycogen and buildup of glucose respectively. These two procedures, these two processes keep happening side by side, and when there is an imbalance between these two, there is a chance of elevation of blood sugar levels or drop of blood sugar levels, which is characterized by severe symptoms. So this diagram shows what is happening in our body during glucose homeostasis. As we know, the glycogen is stored in the liver as a storage component. Whenever the blood glucose levels are down, this glycogen is broken down and sugar is released into the circulation. When there is excessive blood sugar in our body, that in turn goes and gets stored as glucagon in our liver. So whenever we need it, like go down, the liver gives back our blood sugars so that the blood glucose levels are maintained normally. In fed state and in fasted state, there are two different activities which are going on. In a fed state, insulin dominates so that the insulin acts on the blood glucose levels and reduces the blood glucose. In a fasted state, when we are having low blood glucose levels, the glucagon in turn breaks down and releases blood glucose, and it helps to increase the blood glucose level in the peripheral blood. So what is hypoglycemia? It is a common side effect of diabetes therapy, resulting in a lack of adequate cerebral glucose supply. As we know, the brain is the most important organ which needs maximum glucose supply. Other organs can also do away with the low sugar levels, but brain is the first organ which reacts to hypoglycemia. As I told, hypoglycemia can happen even when patients are not on any diabetic medications. It's a physiological hypoglycemia when there is excessive breakdown of glucose but the supply is less. Example for long duration of fasting. And some of these hypoglycemic episodes may lead to a range of neurogenic and neuroglycopenic symptoms. That is, patients can even go for coma, and some of them with severe profound hypoglycemia can even die. So it is very important and prudent that we recognize hypoglycemia and manage it in an efficient way. Classification of hypoglycemia: there are 3 levels of hypoglycemia: level 1, 2, and 3. When the blood glucose levels drops to less than 70 milligram per liter, it is known as level 1, and it has to be within 70 to 54 milligrams per deciliter. And in level 2, it further drops below 54 milligrams per deciliter. And in level 3, there is severe drop in blood glucose levels, and the patient will have symptoms like coma, which needs immediate treatment. Several predisposing factors for hypoglycemia, like old age and poor health, that is when patient has a diarrhea or any poor food intake, chronic vomiting syndrome, all these types of malabsorption syndrome as well. These type of patients can have repeated episodes of hypoglycemia. And also people who are diabetic, who are taking insulin and other OHA drugs, especially sulfonylureas, are also more prone for hypoglycemia. And the patients who are having a habit of excessive alcohol intake are also more prone for hypoglycemia as well as dehydration. Relative therapeutic insulin excess. This is the condition in which the patient continues to take the normal regular dose of insulin, but the food intake is reduced. That can be one chance. Other probability is that patient who is having a reduced food intake due to several reasons, and patient who is having a loose stools or vomiting episodes, who continues to take the regular dose of insulin, also are prone to hypoglycemia. So when the patient is having a poor intake, or when the patient is having a diarrhea or vomiting, we have to advise them to cut down the insulin dose, and also to maybe to skip off 1 or 2 doses of insulin depending on the intake. This is very important, and we have to advise the patient as well as the family members regarding this. And other causes of hypoglycemia like CKD and insulinoma, that is a tumor of pancreas, as well as liver disease, hypothyroidism, starvation, and other metabolic errors also can lead to hypoglycemia. Now, going on to the clinical features of hypoglycemia, we all are aware of most of the symptoms. The symptoms are broadly classified into autonomic and neuroglycopenic symptoms. Autonomic symptoms include trembling, palpitations, sweating, anxiety, nausea, and tingling sensations. And the neuroglycopenic symptoms are difficulty in concentrating, confusion, weakness, drowsiness, visual blurring, and difficulty to speak, headache, and dizziness. Some of the patients who have profound hypoglycemia are do present with the confused state. We can also have a confusion that the patient may be having any psychiatric symptom as well. So first, when patient is having a confused state, we have to look for blood glucose levels at that time to exclude hypoglycemia. So what are the different symptoms based on the blood glucose levels? As the blood glucose level drops, the symptoms vary from mild cognitive dysfunction, sweating, to tremor, and in severe cases, there can be convulsions as well. When the blood glucose levels drop to less than 40 or 30, the patient can go for coma as well. Why is hypoglycemia detrimental? We have to know, and we have to find out that the patient is having hypoglycemia. Only then we can treat the patient accordingly. In the ICU setting, non-iatrogenic hypoglycemia serves as a harbinger of mortality. That is, when the patient is not monitored properly, patient can go for profound hypoglycemia and even can die on the bed. By contrast, in the outpatient setting, insulin-induced hypoglycemia also can be lethal. When a patient is having a labile blood glucose levels, even if we step up the insulin by 4 to 6 units also, patient can have severe hypoglycemia, especially with the rapid-acting insulin and analogs also. We have seen some of the patients who have hypoglycemia episodes with even small increase in the doses. So we have to keep monitoring the blood glucose levels. It is better to ask the patient to have a glucometer by their side. And if they experience any mild symptoms, we can ask them to check the blood sugar levels at their home itself. And for some of the patients, we also recommend using CGM. That is also one way to keep an eye on the blood glucose levels. among the peoples with diabetes, mortality rate due to hypoglycemia is reported to be as high as 10%. And by seeing this percentage, it feels that it is better to keep the patient on a higher blood glucose level. That is also wrong. Depending on the patient's condition and the age group, we have to target the blood glucose levels. Insulin-induced hypoglycemia has been considered responsible for nocturnal deaths, and some of the patients may even die in their sleep. So when we are giving short-acting and ultra-short-acting insulins, we have to be careful and monitor the blood glucose levels very carefully. When the patient is awake, they can report to you with the symptoms, but when they are sleeping, they won't be able to report the symptoms of hypoglycemia. So it is better and prudent to give low doses of insulin during the night. And it is also better to have a peakless insulin, like a long-acting insulin, which is more safer and it is less known to cause hypoglycemia. And coming on to the next, mechanism of hypoglycemia remains unknown, but hypoglycemia has been associated with ischemia and angina also. It also increases the markers for thrombosis and inflammation, and potentially increases the risk of acute thrombotic events and development of atherosclerosis. And deaths due to arrhythmia also has been on the rise because of hypoglycemia. Almost 77% of the patients who are included in this origin trial had increased risk of arrhythmia and death. And target glycemic goals should be individualized, and we have to keep an eye on hypoglycemia and take measures to avoid hypoglycemia and the complications due to hypoglycemia. Now coming on to the proposed mechanism of spontaneous hypoglycemia-induced arrhythmias, as I had mentioned earlier, hypoglycemia is a harbinger for arrhythmias, which happens both in the day and at night. The simple mechanism is by hypoglycemia stimulates the sympathoadrenal response from the brain, which acts on the heart, and there is a compensation by parasympathetic counteraction. This leads to ventricular premature beats and QT prolongation. There may be severe arrhythmias also, and patient may have emergency condition in which they have to be rushed to the ICU or to the emergency department. During night, the same thing happens. Hypoglycemia stimulates the brain, and it, as I told, brain is an organ which demands maximum glucose in our body. There is a blunted sympathoadrenal response, and the parasympathetic counteraction takes place. And even VPCs, bradycardia, and ectopics are very much possible in the night times. Some of the patients do present to the emergency with hypoglycemia along with the arrhythmias. So hypoglycemia and cognitive impairment, as I had already mentioned, the brain is the organ which detects symptoms of hypoglycemia at first. Patients may present with confused state as well as blurring of vision and other symptoms. Hypoglycemia also can lead to dementia. Prevalence and clinical significance of neurodegenerative disorders are increasing steadily in diabetic patients, and hypoglycemia is a frequent clinical situation in strict management of diabetes mellitus. That is, when we aim for a lower HbA1c, we are more prone for inducing hypoglycemia in that type of patients. So in elderly patients, we can relax the HbA1c target levels and keep it a bit higher so that we can avoid hypoglycemia episodes. In relatively younger patients, we have to go for stricter HbA1c levels, and that also should not be at the expense of hypoglycemic episodes. Hypoglycemia, well known as an important factor that directly affects the risk of dementia and cognitive impairment. And there are different factors which affect cognitive function in diabetes mellitus. High blood sugar levels, that is hyperglycemia, and increased oxidative stress and endothelial dysfunction leads to micro and macroangiopathy, which in turn leads to cognitive impairment. There can be vascular dementia as well as Alzheimer's disease. There is abnormal insulin action as well as predisposing factors for vascular dementia like genetic factors, depression, and personal habits. So in younger and older patients, there are totally different mechanisms which are taking place, which has to be managed in the early stage. Treatment of hypoglycemia, whenever we see any patient who is having a hypoglycemic episode, they just manage to put some biscuits or any sugar in their sugar into their mouth, but it is not the very right thing to do. Best thing is to have a powdered glucose solution, glucose powder, that is Glucon-D or any glucose preparation, which can be easily absorbed in our body. hypoglycemia treatment requires ingestion of glucose or carbohydrate containing foods. So whenever the patient is having severe hypoglycemia, we have to go for IV dextrose as well. It depends on the patient's situation as well as the blood glucose level at that point. The use of glucagon also has been indicated in people who are unwilling or unable to consume carbohydrates by mouth. When the patient is comatose and when the patient is not awake, we cannot ask the patient to take anything orally. And especially if the patient is old and bedridden, that can itself lead to aspiration. So it is better to give parenteral glucose, or else we can start a glucagon infusion as well to these type of patients. And newer solutions like disposable tablets of glucagon also are available. You can just keep it under your tongue, or you can just chew the tablets. Glucagon will easily, dextrose also will be available in this type of preparations. And the intranasal glucagon is also available at present. It is approved by US FDA also. Glucagon solution is also available. And next, this is the flow chart which shows how to manage hypoglycemia. First, when we look for this hypoglycemia patients, we have to check the random blood sugar at that point. If it is equal to or less than 70, we have to start the treatment for this patient. First, look for the patient's response. If the patient is responding or not, then the two branches go either way. If the patient is responding, and if the patient is not taking orally, that is, the patient is nil per orally, we have to start 15 to 20 grams of oral carbohydrate and assess response. If the patient is NPO, then we can have to start IV access and give the dextrose, 50% dextrose infusion, or a glucagon 1 mg intramuscularly if the IV access is not available. Then again recheck the blood glucose level in 15 minutes. If the blood glucose level is greater than 70, then we can just monitor the patient and start oral glucose therapy along with meals and snack. If the patient is not improving, then retreat the patient with 15 to 20 grams of carbohydrate and again recheck the blood glucose after 15 minutes. Now, if the patient is not responsive, we can directly go for IV access and administer 50% dextrose infusion and glucagon 1 mg intramuscularly, and assess and reassess the status of the patient every 15 minutes. If the patient becomes responsive, then well and good. Continue with the same management. If the patient is not responding, the patient has to be shifted back to the ICU and monitored rigorously. And the other flowchart, which is merging with the previous one, if the CBG is greater than 70, then retreat the patient with 15 to 20 grams of carbohydrate and continue monitoring every 15 to 20 minutes. After the patient becomes stable, you can shift the patient back to the ward and then keep the glucometer ready and ask your staff nurse or the patients to attenders to check the blood glucose levels. Prevention of hypoglycemia, as I had told you, as we are mainly focusing on the treatment of hyperglycemia. Hypoglycemia is also one of the negative aspects of treating hyperglycemia. It is very important and critical for the component of diabetic patients. SMBG, that is self-monitoring blood glucose, and the CGM devices are also very important, and they contribute much to this monitoring of the diabetic patients. And the CGM graphs are also available, and it is easy. It can be even transmitted from the patient's bedside to the doctor's mobile, and the doctor can also note the readings on the CGM monitor. Patients should also be aware of the situation that increases the risk of hypoglycemia, like specific intake of particular food substance or certain drugs. Now, the main topic for today is about DPP-4 inhibitors and hypoglycemia. The evolution of DPP-4 inhibitors started from 2006, that is FDA approved sitagliptin. There are other gliptins like vildagliptin, saxagliptin, allogliptin, and linagliptin. Linagliptin is a very important drug since it doesn't need dose modification in renal compromised patients. And recently there is teneligliptin also, which has taken the Indian market by surprise. There are many physicians who are prescribing teneligliptin to their patients. And these gliptins are a very important group of drugs, and they have moved up the recommendation ladder of ACC and AHA. DPP-4 inhibitors as an anti-diabetic drugs. They can be used as first-line therapy when metformin is not tolerated. As we all know, metformin has stood the test of time for more than half a century. We have been prescribing metformin, that is the bread and butter for all the diabetologists. Along with metformin, when the patient is not on adequate control, we can add them on either sulfonylureas or DPP-4 inhibitors. But sulfonylureas have the risk of inducing hypoglycemias. So nowadays, it is better to start the patient after metformin. We can go for DPP-4 inhibitors or SGLT2 inhibitors. Only the cost is one concern about SGLT2 inhibitors. But nowadays, even remogliflozin has come up and it is comparatively less costly. But coming back to our topic, that is DPP-4 inhibitors, they are used mainly as add-on therapy to metformin, and particularly when there is a desire to minimize the risk and weight gain for hypoglycemia. DPP-4 inhibitors at present included in the guidelines, as I had said, ACC/AHA guidelines. How are the DPP-4 inhibitors unique in their action? This is the physiological site of incretin action. There are some hormones named as incretins, as we all know, in our body. That is GLP-1. It is present even in different organs. It acts on heart, brain, and stomach. Decreases gastric emptying and increases insulin biosynthesis. And it also has effects on liver, that is decreases the glucose productions. GLP and GIP, all these two hormones are very important. Incretin hormone system is shown in this cartoon. As we intake food, it reaches the stomach and intestine, and it stimulates this production of GLP-1 and GIP, which are released from the GI tract after a meal. So what happens is that this DPP-4 is inhibited, which leads to control in blood sugar levels after we give this DPP-4 inhibitors. So that is the action which increases the action of glucagon, and also it controls the blood sugar levels. DPP-4 inhibition will give only meal-dependent increase in insulin secretion. It also provides sustained glucagon counter-regulation. So in one arm, as the insulin is reduced, glucagon is also increased in the other arm. So DPP-4 inhibitors has dual mode of action. Then coming on to the difference between binding of sulfonylureas and GLP-1. Sulfonylureas act by binding onto the SUR receptor, that is sulfonylurea receptor. It is a potassium channel. It acts on the potassium channel and reduces the intake of blood glucose. In GLP-1 receptor, it is a G-protein coupled receptor, which acts as internal and external sites. It is a cyclic AMP activated pathway, and there are other enzymes like phosphoinositol 3 and PKC. Here, the insulin secretion with the GLP-1 binding is dependent on glucose intake, unlike sulfonylureas. In sulfonylureas, it is dependent entirely on the intake of glucose, but in GLP-1 and GIP, it is not dependent on the glucose intake. DPP-4 inhibitor mechanism of action. When food enters the small intestine, GLP-1 is produced. It increases the insulin secretion and suppresses glucagon secretion. There is an enzyme called DPP-4 which inactivates GLP-1. So this DPP-4 is responsible for increasing the blood sugar levels. When we inhibit this DPP-4 enzyme, it helps to increase the concentration of GLP, thereby increasing the insulin stimulation and suppressing the glucagon secretion. That is why we are blocking this DPP-4 enzyme by giving DPP-4 enzyme inhibitors. Pleiotropic mechanism of DPP-4 inhibition. There are different pleiotropic effects. It increases insulin secretion, decreases the glucagon, already which I mentioned, and it also acts through the DPP-4 inhibition in the gut, pancreatic islets, and other peptides like GIP and SDF1-alpha. And effect of DPP-4 inhibitors on hypoglycemia. It has low risk of adverse events, including hypoglycemia. Even metformin doesn't produce much of hypoglycemia. So the better combination is to give metformin along with DPP-4 inhibitors. Meal-dependent increase in insulin secretion occurs, and even when the patient is having a reduced meal, and when the patient is taking the usual dose of DPP-4 inhibitors, patients are not prone for hypoglycemia. This is the major highlight of using DPP-4 inhibitors. And there is a sustained glucagon counter-regulation, which helps to keep the blood glucose levels in check. Glucagon suppression. Vildagliptin was shown to exert its suppressive effect on glucagon secretion in the absence of endogenous insulin. in patients who have very less insulin in their body. This leads to low glycemic variability and very low hypoglycemia. Glycemic variability is a very important factor in which patients who have same HbA1c levels, that is, those who are not under control and those also under control within the day, that is, intra-day blood glucose levels can be high and low, but the HbA1c will be normal. In this type of patients, it is better to look for a glucose monitor. Incidence of severity of hypoglycemic events with vildagliptin and glimepiride. When we compare both vildagliptin and glimepiride, vildagliptin had lesser events of hypoglycemia, whereas glimepiride had more events of hypoglycemia since it is sulfonylurea. DPP-4 inhibitor guidelines. As I told in this guidelines, the DPP-4 inhibitors have come up and they are almost next to metformin. That is highlighted over here. After the patient is having ASCVD or a CKD, those who are without the ASCVD or CKD can be taken up for any other drugs, and those who are specifically having any ASCVD or a CKD, they have to go for better, stricter blood glucose control. And patients who are on CKD have to have a dose adjustment according to which gliptin we are choosing. And insulin is also safer to use in this type of patients. Now, summarizing, hypoglycemia can be a major limiting factor while treating diabetes. Fast-acting glucose remains the first choice of hypoglycemia treatment. That is a dispersible glucose or a powdered glucose. And we can also give a dextrose orally chewable tablets. And in severe hypoglycemia, we can go for IV dextrose, or else we can go for glucagon infusion. DPP-4 inhibitors provide an option as they are one of the safest anti-diabetic drugs to be used. And I once again thank the organizers for giving me an opportunity to present this webinar. Thank you.
Thank you, sir. Thank you so much for a wonderful presentation.
I hand over the mic to the organizers.
Yeah, thank you, sir. Thank you so much. Wonderful presentation. Given the paucity of time, sir, I'll keep the question and answer session very brief. I'll ask my first question to Dr. Arun Pari. So, sir, what we wanted to know is how is the decision of the treatment guided? Like if it's with compelling indications or without compelling indications. So, how do you decide on a drug class of particular antihypertensive drugs?
Sir, I didn't get you.
Yeah, sir. I'll repeat. So, sir, what I was asking is when it comes to different drug classes like ACE inhibitors or ARBs or CCBs or etc., how the treatment decision is guided. So the guidelines usually say, with compelling indications and without compelling indications. So how do you decide between, especially the ARBs, when you prefer ARBs over others?
Yeah, in patients with diabetes, the first choice would be an AC or ARB. And in patients with coronary artery disease and LV dysfunction, an ACE-ARB along with beta blocker and an additional diuretic that is thiazide and a mineralocorticoid receptor antagonist like spironolactone or eplerenone is usually used. And in patients with chronic kidney disease, we first start off with ACE-ARB and then up-titrate with calcium channel blockers and beta blockers. And especially end-stage renal disease, we may also have to use alpha blockers like trazodone and even centrally acting receptor antagonists like moxonidine and clonidine we may require. Yeah.
Okay.
In young patients without any risk factors or any other complications, we prefer to use thiazide diuretic and ACE-ARB. And we generally avoid beta blockers because it may cause fatigue and sexual dysfunction. So,
okay. Yeah. Okay, sir. Thanks. Thank you so much. My second question is for Dr. Sriram. So thank you so much for the DPP-4 inhibitors part of it. So as you must be aware, we have both the teneligliptin and vildagliptin in our portfolio. So if you can just share a couple of thoughts on both the molecules, like which subpopulations, which indications, how do you decide on them?
Initially, when teneligliptin was launched, many companies came up with different brands, and I even saw some of the companies who came up with two brands with the same company. So there was a lot of marketing going on for teneligliptin. But actually, there was a talk like teneligliptin can increase the QT prolongation. So there was some doubt regarding the use of teneligliptin. But one point of clarification is that the QT prolongation was only with the but we don't use that much dose in clinical practice. That was only on experimental trials. So it is safe to use teneligliptin, and along with the metformin, it gives a very good blood sugar control. And second one is that vildagliptin, it was initially very costly since the patent expired recently. Other companies came up with the brands. So the innovator molecule had completed the patent. So many companies came up with the different brands of vildagliptin, but only advantage is that it is very easy, and you can adjust the dosage of vildagliptin more easily, and the patient is also very comfortable taking vildagliptin. They have not yet reported any adverse effects with the vildagliptin, and along with metformin, it is very efficient in reducing the blood sugar levels. And also in patients who are taking insulin, vildagliptin helps to reduce the insulin dosage. When we give a good dose of vildagliptin, we are able to cut down on the insulin dose. That is also one observation which I have seen. And now that the bonanza has come, the cost has reduced considerably. Even we get it below 10 rupees per tablet. So even patients are much affordable, and they're happy to use vildagliptin.
Great, sir. Thank you so much for your insights. I thank both the speakers, and without wasting any further time, I request Mr. Manish Shirishkar to do a vote of thanks.
Thank you, sir. Thank you, Dr. Arun Pai and Dr. Sriram, for your wonderful speech and thorough presentation on the respective topics during the today's e-Gurukul program organized by Indiabulls Pharmaceutical Orion Division. Sir, I would also like to thank Dr. Abhay Mane for being a moderator of this event, and Mr. Girish Malhotra for setting a tone of this online event. Sir, I would like to tell you that almost more than 900 logins for today's e-Gurukul program. So it's a wonderful program that we had today. And moreover that, more than 100 participants from Tamil Nadu area. Definitely, it's a good for us to have a wonderful speaker with us today, sir. Thank you very much, sir.
Thank you. Thank you.
And sir, on behalf of you both of us and from the Indiabulls Pharmaceutical, I would also like to thank all the participants to attend this today's program. Definitely, we will continue to have this e-Gurukul program henceforth. The next date is 26th September. Please keep updated yourself and stay safe. Very soon we will meet. Thank you. Thank you all.
Thank you. Thank you so much. Thank you. Bye. Bye.
Thank you.
Thank you. Thank you very much.
Thank you, sir.